Some end-stage therapies, the stem cell transplants, very limited information there. We do see a lot of our patients, unfortunately, spending their whole life savings going to other countries to get stem cell therapies, that are kind of promised to them. There's even some companies called the Lung Institute, and it's podiatrists and pediatricians running it that are not pulmonologists, offering them stem cell therapy. So I always tell patients to be very careful. But the hematopoietic stem cells are what are, if they're going to do those types of therapies, that's the only area that we have very minimal research in. Lung transplant, absolutely, these patients need to transplant sooner than you think they do. So always want to make sure they get a referral very early. It's very difficult, especially with underlying autoimmune, and especially if they've got scleroderma because of the dysmotility issues that we have with those patients. And a lot of times they get denied their perfect candidate outside of their achalasia or whatever's happening because they don't want to risk aspiration post-transplant. Do you want to take some more multidisciplinary?
You can.
Okay. I think she covered this very well. Wendy did, just making sure we're getting pulm and GI and rheum and everybody together to make sure that we're managing these patients very closely. Sometimes cardiology even involved. If your pulmonologist is not managing the pulmonary hypertension side, your cardiology team likely is. These patients tend to overlap a lot of disease states. These diseases don't happen in a silo. They like to happen together and run in packs, like she said. Also talking very early about palliative care, and hospice should happen earlier before they need hospice. That discussion should happen. All right, so overview, very difficult population, oftentimes difficult to diagnose in the early stages. Can progress, unfortunately, has a very high morbidity and mortality. Prognosis can mitigate further fibrotic changes other places in the body. We want to try to preserve their status, preserve their lung function as long as possible. New therapies are coming. We have new established therapies, which are great. And we want to make sure that we're getting them into multi-specialty cares and also talking about what is their goal. Because a lot of these patients, their goal may not be to even treat it. They're happy. Because some of these patients, a lot of these patients with ILD are like 80 and 90. And they're like, I got to die of something. I feel pretty good right now. Just make me comfortable. And so those are the patients who make sure we're meeting their goals. That's where palliative care definitely helps if you don't have the time to speak with them.